All right, good morning, everyone. Thank you all for attending this session, and thank you to our speakers, Allison Goodwin and Julie Bayer. Please accept this small gift, and in the interest of time, I would let you introduce yourselves and get right into the presentation.
Thank you. Thank you. That's pretty. All right. Hi, everyone. Thank you so much for having us. Is this, can you hear okay with the microphone? Okay. Great. So I'm Allison Goodwin. I am one of the genetic counselors just right up the hill at VCU.
And my name is Julie Bayer. I'm also a genetic counselor at VCU Health.
Yes.
Okay. So we're going to bounce back and forth on our presentation. Let's see here. So just kind of a little disclaimer in advance. We're not able to talk about specific people or specific situations, but if you have concerns for yourself, a loved one, a family member that you feel like could benefit from a genetics evaluation, please reach out to our scheduling line 804-828-9632, and we can help get you hooked up with a genetics evaluation. Excuse me, if you feel like that's something that you or a loved one could benefit from. And we ask that questions just be held to the end. We saved a lot of time at the end for questions, so we'll just ask that we hold questions till the end. So a little bit about why we're giving this presentation today. As genetic counselors in the genetics community, we share common goals with organizations like the ARC. People first, always making sure that we are best serving the people that we are working with, people that have come to us for our services, working in a collaborative way with our patients, with their healthcare team, with their families, with their loved ones, and with organizations and resources in the community for them to make sure that they are getting the support and services they need to live as happily and successfully as possible. And then supporting people through the genetic diagnosis process, this genetic testing odyssey, and through whatever diagnosis they may receive if they're able to get a diagnosis, and help making sure that they have the supports that they need in place as a result of their workup with genetics. So we have a very reciprocal relationship. Many individuals who have intellectual or developmental disabilities also have an underlying genetic diagnosis that causes those intellectual or developmental disabilities. And many families of people who have intellectual or developmental disabilities are referred to genetics for an evaluation at some point throughout their life. And many of the families that we work with are referred for early intervention or support services after they've seen us. So after they have a diagnosis and after we have completed our workup, we will refer them to get those additional supports as needed. So part of what our goal is today is to kind of demystify, kind of pull back the curtain on what exactly a genetics referral and an evaluation looks like, and how it can help families, how it can help other members of a person's healthcare team. And we in genetics very much believe that information is power. And by sharing this information with you and allowing you to understand what genetics can do, it can help you help your friends and your families and your loved ones have a better idea of what is going on, and it can help give more information to healthcare providers to help families. So our goals for today, we're going to do a little bit of a genetics 101 introduction. We're going to talk about who should consider a genetics evaluation, then talking about what happens during a genetics evaluation. What does this process look like? Review a little bit about some of our more common genetic testing options, and then talk about where we go after genetic testing takes place.
All right, thanks, Julie. So yes, we wanted to give everyone just a smidge of background information. I know everyone is probably coming at this with different levels of exposure to biology, genetics, science. So we'll kind of have some relevant facts, and definitely, again, we'll have time for questions at the end. First of all, though, just a few fun facts about genetics. You will see why we love this field of study. So unless you're an identical twin, your combination of genes is unique. I think that's really important. Just as we talk to our patients about, everyone has differences in their DNA, and it's what makes us individuals and makes us special. For each of our cells, when they need to copy the DNA to make a new cell, it takes actually about 8 hours for it to work through all of that information. And then again, just to give you an idea of how much information is contained in our DNA, if you were going to start reciting the letters of your genetic code, rate of 100 letters each minute, it would take you 57 years to get through all of that without stopping. That I actually did not know that. I'm not sure where you found that factually. And then this is another fact that I was not aware of. Of these species, which has the highest number of chromosomes? We have a small enough group. Does anyone have a guess?
Gorillas?
Can we get a guess?
Humans.
Oh, the fruit fly.
All right, ready? What'd you guess?
Amoebas.
Amoebas. Okay, of the 4 on here, we've got butterflies. So it seems to vary by species, but we found numbers up to in 300s, I think.
There's one species that can have between 448 and 452 chromosomes, whereas humans have 46.
Yeah. Yes. So science, you get surprised every day. But yes, leading into this idea of chromosomes, as Julie just said, typically humans are expected to have 46 chromosomes. They come in pairs, as you can kind of see on this diagram. In each pair, one copy comes from biological mother, one copy comes from biological father. It's how we are a combination of both sides of our family. Now, clearly there can be differences in this chromosome number. We'll get to that, but this is kind of what we typically expect to see. Busy slide, just to give you the main idea of kind of the underlying thought process with a lot of genetics and a lot of our testing. So our body is made out of billions and trillions of cells. Each of these cells contain genetic information. The genetic information is packaged into chromosomes. So these little X-shaped structures that you see there, and those actually can physically be seen with a microscope. The chromosomes are made up of very tightly packaged DNA. So like this double helix strand that we always see. And it's really tightly packed and wound around each other into those X-shaped structures. Along the DNA strand itself, there's the code. So these letters you see, the A's, the T's, the G's, the C's, there's only 4 letters in our genetic code. Depending on the order that they come in and which ones are paired with other ones, it changes what the code says. So each individual code makes up a particular gene or a particular instruction for our body to follow. Our body then uses those instructions to make proteins. Proteins can be all kinds of different things. They carry out all the various roles in our body. Again, very busy, complicated slide, but just chromosome made up of DNA. DNA is composed of various individual genes, and then the genes do the job of making a protein. One analogy that we really like to use that I think is quite helpful for understanding this is thinking of, again, our DNA and our genetic information as sort of the instruction manual for our body. So the whole book, the whole volume that would be your genome. That would be all of your genetic information. You might then think of it as being divided up into various chapters. So 46 different chapters for each of the individual chromosomes. And then those chapters are broken up into various words and sentences that when your body reads through them, it reads those instructions and can do what it needs to do. So whether that is determining your eye color, your height, again, various issues with development or health concerns, all kind of plays into that.
Okay, so now that Allison has kind of given the background about genetics and genetics in our body, so we're going to talk about a little bit about who should consider a genetics evaluation and kind of some of the more common reasons that we see someone come in for an evaluation in our department. So several reasons to consider a genetics evaluation. The most common that we see is developmental delay, intellectual disability, and autism. So developmental delay can be isolated to motor delay, speech delay, or it can be global developmental delay, where it's developmental delay that is across several domains. And intellectual disability, so someone who is struggling in school, maybe not able to finish high school and not able to live independently as an adult, or somebody who has a diagnosis of autism. Then we see babies who have had their newborn screened. So every baby in the United States, but especially in the state of Virginia, gets a heel prick before they go home from the hospital, and they get screened for certain metabolic conditions, other conditions like sickle cell anemia, cystic fibrosis. And if that screening comes back abnormal, they'll get referred to genetics for us to work that up, confirm if that is a legitimate diagnosis, or confirm if that is just a positive screen that we don't need to do anything further for. Muscle tone differences. If a person or a child has very weak muscle tone, something that can be called hypotonia, it can be also called like floppy baby. So baby can't support their head, can't support their body weight. Or if somebody has abnormally strong muscle tones like hypertonia, that also can be indicative of genetic conditions. So that's a reason for referral as well. If a child is meeting their developmental milestones and then kind of hits a plateau and they've stopped, so their speech has stopped, or they started walking but they're not running, or if they hit their developmental milestones, they were speaking in sentences, and then they're only speaking in 1 or 2 word phrases, and then their speech continues to regress, that's definitely concerning. We would like to see somebody in genetics for that. Unusual skin findings or markings. If people have lots of what we call cafe au lait spots, so they look like brown birthmarks, that can be indicative of several genetic conditions, including one called NF1, a neurofibromatosis type 1. So we'd like to see somebody in genetics because there are downstream screenings that would be recommended for somebody with that kind of a diagnosis, because that can affect multiple parts of the body. Multiple birth defects, either major or minor, hand, foot, limb differences, microcephaly. So if a person has a head size smaller than we would expect, or a head size larger than we would expect, those can also be associated with genetic conditions. And if you have multiple family members with similar features, that's kind of a hint to us that that could be something genetic. So that's a reason to consider coming in and seeing us. Other reasons for genetics evaluation. So Allison and I practice what's called general genetics or medical genetics, pediatric genetics. Basically, we see people that are already born, but are not being seen for anything related to pregnancy, or not being seen for cancer, heart disease, and not seeing somebody maybe when they're considering having a pregnancy. But other reasons for a genetics evaluation: when a woman is going to be 35 or older when she delivers her baby, we know that there's an increased risk of having extra chromosomes. So that's something like Down syndrome, trisomy 13, trisomy 18. The chances of that go up as a woman gets older. So a genetics evaluation could be available to her if that's something that she would be interested in when in that situation, to learn more about the chances of having a child with one of those conditions. If a couple is experiencing recurrent pregnancy losses, so 3 or more miscarriages, then we would want to see somebody, or we would like to see somebody in genetics, just to evaluate for if there's a cause for that recurrent pregnancy loss, and if that has a genetic cause. And then if somebody has a family history of cancer or heart disease, so the things that kind of stick out to us as cancer or heart disease having a genetic component: early ages of onset, so like breast cancer in women diagnosed before the age age of 50, sudden cardiac death, multiple relatives with the same or related cancers or heart disease. So multiple women in a family having breast cancer, multiple generations of women, or multiple women in the same generation having breast cancer. Or if one person has had more than one type of cancer, we would definitely recommend a genetics evaluation just to see if there is a genetic component, can help us have an idea if there's any more screening that would be recommended, so we could catch any other disease that would manifest as early as possible. And then they could have an idea if their family members, if any of their relatives are also at risk and need to undergo screening for themselves. So our referrals to genetics most commonly come from pediatric neurology, developmental pediatrics. So when somebody is seeing developmental pediatrics and getting a diagnosis of autism or developmental delay, intellectual disability, they'll often refer to genetics. And pediatricians, we get a lot of referrals from pediatricians within VCU Health, but then we also get referrals from pediatricians in the community. So the information, we've kind of touched a little bit about this, but the information that we can get from a genetics evaluation, if we are able to find a genetic diagnosis, we can get information about the condition. So we can say, this is what it is. This is what we know about this condition based on the other people who have been diagnosed. Some conditions such as like Down syndrome, Turner syndrome, trisomy 13, trisomy 18, we have a lot of information about those conditions, and we are able to have certain guidelines that we follow that have been published by professional organizations. Other conditions are not as well described in the literature. So sometimes that's just saying, okay, this is the condition, this is what we've seen in other people, this is something that we might want to look out for X, Y, and Z. Doesn't necessarily mean that this person will get it. Kind of when we have a situation like that, each person tells us their own story when they have that diagnosis, and we are a player on the team to help make sure that that person has all the supports in place that are necessary. So it can give us information about the short-term and long-term prognosis. So what should we do right now in this moment? What referrals are necessary right now that we have this diagnosis? And then what does it mean for the long term? You know, is this person going to be able to live independently? Is this person going to be able to live well into adulthood? Having that information where available. Treatment and management. So if there are specific things that are recommended, if someone should go have an ultrasound of their kidneys, if someone should go have an ultrasound of their liver, if someone should see neurology because their condition has an increased risk of having seizures, those are things that we can gain from a genetics evaluation and getting people hooked up with those correct providers. We can learn how this was inherited, if this is something that was new in somebody, or if this is something that was inherited from their parents, then what the chances are that that person's parents would have another child with a condition similar to this, and what the chances are of that person having a child with a similar condition. So similar to this, the next points, I just jumped ahead. And then kind of the psychosocial aspect, having a name, having an end of the diagnostic odyssey, being able to say, yes, this is what it is, validate for families that, you knew something that was going on, this is what it is, and this is what supports are available to help you with this diagnosis.
Right. So so now we know a little bit about like what we might hope to gain from someone being seen in genetics. But just wanted to give you all kind of an idea of what it actually entails when we do this evaluation. I think this is really something that's kind of behind the curtain for a lot of people. We have a lot of families and patients come in and they really have no idea what to expect. They've just been told to come to genetics. And I think it can be a little bit daunting, but I think it's helpful just to know exactly what goes into it. So just thinking about where do we actually fit in within the medical system, I would say that we are lucky, I think, in our job that we get to be quite multidisciplinary. We really get to work with almost every other department in the hospital because our DNA, our genetics underlines all of our health. And so there are genetic factors related to really every area of medicine. And so we tend to play a role a little bit as detectives, I would say, in the genetics department, where most often patients are referred to us because there's either a suspicion that something genetic is going on, or we want to try and put a name to what is happening. And so we really need to look at all the available information, really look at the big picture to try and do that and help how we can. And so we work quite closely with many of those different departments to figure out what our areas of concern are, what we want to target. So that's kind of I would say our main job is being those detectives, identifying the why of what we're seeing. Sometimes, as Julie was saying, if we have a particular diagnosis that has been made, it helps us to know things to look out for in the future, things that may be more common that we want to be able to either prevent or manage at an early stage. So looking forward is a big part of this too. And then there are some, there's many times where we might get a particular diagnosis and then we release the patient back to their other providers in the various specialties to continue following. But there are some of the very specific genetic conditions, so like Down syndrome, like trisomy 18, neurofibromatosis, where we have very set in stone guidelines from the expert societies, and we can really help manage all of that care for some of those patients. And sometimes there's specialty clinics that do that too, specialty genetics clinics. So why is it important to see an actual genetic specialist when you're thinking about this evaluation and testing? We know that anyone can order genetic testing. Any physician can do that. It's out there. It is complicated. I think you're probably getting that sense as we go through this talk. We do have quite specialized training in thinking about what is the best test for this patient. Do I want to start with a smaller test? Do I want to go straight to a bigger test? What is most efficient for my patient and their family, both kind of along that diagnostic odyssey to try and get to the root of things as quickly as we can. Also, financially, that can make a difference. We also really focus on both pre and post-test counseling for our patients and their family members. Genetics is a part of medical information, you know, and everyone should have access to that. There are some things about genetics that are a little bit specialized that you don't come across in other areas of medicine that can be really helpful to understand beforehand and make those informed decisions about what the testing is going to entail and expect and what to expect when those results do come back. Our interpretation of genetic testing can also be somewhat complicated. We'll get to that on a couple of additional slides. Rarely is a genetic test going to give us a black and white yes or no answer. There's often room for shades of gray there, and it changes over time, our understanding and our interpretation of genetics. So those of us within this field are keeping up with that literature and that data. So yeah, just to get the idea that, again, anyone can order this testing, can kind of understand it at the end of the day, but actually going through the process can be quite nuanced. It can affect, you know, potential financial outcomes, insurance things. So we just always want our patients to feel informed as they move forward with this process. We sort of touched on some of the insurance type information. We won't go super into detail with this, but it is a question we get asked fairly frequently. So in terms of doing this testing, is there the possibility of discrimination based on a genetic status? There is a federal law, so passed in 2008, GINA, the Genetic Information Non-Discrimination Act. This applies to all states. Again, it's federal. Different states also have some of their own protections in place, but this applies to everyone in the country. So it states that an insurance provider, a health insurance provider cannot discriminate against one of their clients based on the status of a genetic testing report. So in other words, they can't decline you coverage, they can't raise your rates based on genetic information. Same with employers, they cannot make hiring or firing decisions based on genetic information. So we do have protections in place. GINA does not cover everything, though. It does not protect life insurance, long or short-term disability insurance. In theory, those types of providers could deny coverage or raise rates if you were known to have some certain genetic risk factors. GINA has a couple of other exclusions. It doesn't apply to members of the military. It doesn't apply to like very small employers. I think it's 15 or less. So it's not something that maybe comes up every day, especially if you or your loved one are an individual who maybe already has some underlying health issues. But particularly if we're thinking about things that could come up in the future, if we're going to tell you that you have a risk of XYZ in the future, it may be helpful to kind of have your ducks in the row before you consider testing. So this is something that we pretty regularly talk with our families about.
We really have that conversation when it comes to talking about like finding out if somebody has an increased risk of developing cancer or heart disease, something that could happen in the future, as opposed to where the testing that Allison and I do is usually based on somebody who has something going on right in this moment.
Mm-hmm.
But if it's predictive testing in the future based on like a family history, then GINA comes more into play in those situations.
Mm-hmm. So when you come for a genetics visit, who are you typically going to see? Again, this is more specific to our clinic, the clinical general pediatric genetics. Most of the time you're going to see two individuals. We work as a team. So you have your medical geneticist, that is the physician. They've gone through residency. Most of them do pediatrics, but there's exceptions. And then they do an additional 2-year fellowship in medical genetics specifically. So again, very highly trained. Their role is completing the physical exam. One thing that they are often looking for is like differences in facial features, differences in body structure that individually might not mean anything and might just be part of normal human variation, but potentially taken together could make them lead towards a certain diagnosis or a certain syndrome. So that's part of the physical exam. They ultimately provide the diagnosis to the patient, sign off on the testing orders, basically what you would expect from going to any doctor visit. Us as genetic counselors, again, we're part of the team. We work quite closely together. It probably depends on the facility where you're seeing genetics. Sometimes the two providers will come in together. Sometimes we'll each kind of do our own little part and then report back at the end. But we are really working hand in hand. So we are not physicians. We do a 2-year master's degree in genetic counseling specifically. It's quite an intense program. We have clinical rotations. We try to see all the various areas of genetics. And then after graduation, some of us will sort of subspecialize from that point. So we tend to do a lot of the history taking, reviewing records beforehand, pulling all that kind of detective information together, working on figuring out the testing options, the insurance protocol, getting the sample collected, all the kind of strings behind it. And then often we are the point of contact for discussing the results when they come back, figuring out who else the patient and the family might need to see afterwards. So yes, I think this is basically what we just talked about. This is our lovely VCU genetic counseling group from a week or 2 ago. We're just right up the road. But yes, we tend to be kind of the main point of contact. The physician is always available as well, but it's often whatever genetic counselor you're working with who's going to be walking you through most things, doing an interpretation of the family and medical history, thinking about those psychosocial aspects of testing and the diagnostic odyssey and kind of walking through that as we go. And then again, if we have a diagnosis, educating about, well, how is this inherited? What are the chances for family members? What are the referrals we're going to make for you? Where do we need to go from here? And you have probably gotten the sense throughout our talk, but we are quite focused on having our families and having our patients really make informed decisions and doing what's best in that scenario for them and talking them through kind of what works for that family. One thing that we is specialized to our field is we really focus on family history. Certainly other providers do this too, but if you do have a genetics visit coming up, definitely is helpful to kind of think about the family history. If you know that information, you know, not everyone knows a lot about their family history. Sometimes we might have families where someone is adopted and that information is just not available. And that is totally fine. We can work around that. But if that family history information is available, it can be really helpful to kind of have an idea of the structure of the family. So who's in the family? Are there individuals who maybe have had similar features to the patient for that day? Anyone who kind of fits some of those points that Julie was saying before. So, you know, multiple birth defects, early onset of health conditions, many people in the family having similar conditions. And we go through this in a pretty specialized way just to kind of see what we can gather from that. It's a piece of the puzzle. It's not the only thing that we focus on. So before a genetics appointment, we tend to get pretty detailed medical records. Again, we're really focused on everything. So we tend to try and view all of the notes. Everything could be kind of a clue. So we want to see the cardiology notes, the neurology notes, the developmental pediatrician. We want to pull together everything we can to kind of put those pieces together. So we do tend to do a lot on the front end of reviewing those records. Sometimes we will talk to families beforehand to gather some more information and kind of talk through things. During the appointment itself, again, we're clarifying information from the medical history. So we've reviewed the records, but there's often more questions that we have. We also really try and get a sense of like where this family is at, what have they been told about the appointment, what are their expectations, so we can kind of come to a middle ground and make sure everyone is having their needs met. Again, we ask lots of questions about family history. Typically, the geneticist will do a physical exam. We'll have a discussion together about potential diagnosis. What are we thinking? What testing might be available? What are the recommendations? And sort of make a plan of where are we going to go from here? How's the testing going to work? If the test result comes back one way, what are we going to do? If not, do we have an alternate plan? So a lot to do in that visit. It does take usually about an hour, and we do tend to spend most of that time for most of our patients, but definitely a perk of our job as genetic counselors that we have the opportunity to spend all that time with our patients. We're not just in and out in the 5 or 10 minutes that you might expect with some visits. After the appointment, if there's testing recommended, we have to coordinate that. So getting a sample collected, figuring out insurance coverage, all of the fun stuff that goes on behind the scenes. Once those results come back, again, usually the genetic counselor is the one who is reporting those out, and then potentially making referrals or other recommendations. And then it really just depends on the situation, whether we need to continue following that patient in our clinic. There are some patients who either don't have a diagnosis yet, who we want to see again in a couple years and revisit everything. And so we'll make recommendations for follow-up. There's some patients who have a specific diagnosis that we want to continue help following. But for some patients, you know, it may be, again, we've reached a diagnosis. We're going to kind of release you back to your referring providers, and we're available as a resource, but we don't need to continue seeing you on a regular basis.
Okay, so now that we've talked about what happens before an appointment and what happens at an appointment, we're going to talk a little bit about the genetic testing process. So when we think of genetic conditions, there are kind of three broad categories of genetic conditions. So the first is quantitative. So these are called copy number variants. So this is when there is not enough genetic information, too much genetic information. So something like Down syndrome, trisomy 21, is an extra copy of the 21st chromosome. That's more genetic information than we would expect, can cause health concerns. Something like Turner syndrome, that's missing one copy, females missing one copy of the X chromosome, same thing, that can cause health effects. Then we can have qualitative or sequence variants. So these are when you hear somebody saying that they have like a genetic mutation. So something like sickle cell disease, something like cystic fibrosis. These are the result of qualitative genetic conditions because they are caused by a specific single letter change in that DNA. Then there are things like trinucleotide repeat disorders. This can include Fragile X syndrome. And unfortunately, there is no genetic test that can detect all genetic conditions. So that's part of why you want to see a genetics professional, because we are very well versed in these conditions, more so than a pediatrician, than neurology, than other specialists who might say, oh, I think this could be this, but maybe they don't know how to order the right testing, or maybe they don't know how to interpret the results when they come back, or maybe they ordered broad testing and they said, well, this testing came back negative, so there's no genetic condition, but they didn't order the kind of coordinate or the complementary genetic testing that might help with a diagnosis.
And it changes literally from week to week. You know, we hear so many genetic stories, and there's knowledge that's coming out every week, which is great, but it is hard to keep track of.
Yes, yes, Allison is absolutely right there. So copy number variants. So the most common test that we order there, and this is the most common baseline test, I think this is the most common test that all of us in pediatric or general genetics orders, is something called a chromosomal microarray. And so what that does is it basically just goes through all of the genetic information in all 46 of those chromosomes to first look and see, are there 46 chromosomes? And look to see if there are any, okay, so we have 46 chromosomes, are any of them too big or too small? So it can detect those entire chromosomes that are missing. So they're extra. So extra is a trisomy. So like trisomy 21, trisomy 13, trisomy 18. Excuse me, or a monosomy. So like monosomy X. There are no full so any of the chromosomes, so 1 through 22, chromosomes 1 through 22 are the same in men and women, and those are called our autosomes. And then the sex chromosomes are that last pair, XX in females, XY in males. The sex chromosomes are the only ones that we can be missing one of. So a female can be, or a biological female can be missing one copy of the X chromosome and still survive, but and missing any of those full copies of chromosome 1 through 22 is not compatible with life. And then small or large pieces of chromosomes that are extra, so that would be like a duplication, so this diagram here, or a deletion where there is not enough genetic information. So a very common condition is called 22q11.2 deletion syndrome, 22q DeGeorge syndrome, and that's the result of a deletion of part of the genetic information on one copy of chromosome 22. So the microarray can again find those small extra or large or extra or missing pieces. And so this is an example of, we wouldn't even see this information. The lab just sends us a nice report in a paragraph form that says, oh, this is what's missing. But this is what you would see, that this region is showing that there is a deletion here. So this person is missing this genetic information, and then the lab can tell us what exact genes are involved in that region. And then that can help us have a better idea of what exactly we could expect for the health in that person. So conditions that we can find on a microarray: Down syndrome, that 22q11.2 deletion syndrome, DeGeorge syndrome that I talked about, Klinefelter syndrome. So this is 47XXY. So that's when a male has an extra has 2 X chromosomes and a Y chromosome. Turner syndrome, where a female is missing one copy of an X chromosome, and then Williams syndrome, which is a condition that is missing just a portion of the DNA on one chromosome. So the second type of testing that we do is something called sequencing. So sequencing looks for spelling errors, we call them variants now. They used to be called mutations in DNA. So going back to the beginning of the presentation where Allison was talking about, that our genes are like the sentences in a book. Another way you can think of it is like a gene is a recipe, and that recipe produces a protein. So what it does is it'll go through that recipe, all of the letters in all of those words, and it's going to do a spell check, and it's going to look to see, are there any letters that are misspelled in there that could change the way that that gene works. So the conditions that we find on sequencing are called single gene or monogenic disorders. And when you hear autosomal dominant, autosomal recessive, X-linked, sometimes Y-linked, but not very common, these are what we're talking about, are like these sequencing disorders. So we can get several different types of genetic variants or mutations. So when you look here, like the original sentences, the gray cat ran down the hall. There are some genetic changes that our bodies can absorb and that are fine and that are normal variants. But then when you change some of the variants, so like if you change this H to a B, that's like a missense variant. And that changes the way that that sentence reads. Or inserting 5 letters here, could potentially change everything down the line, or deleting 3 letters, or duplicating some letters, or putting the period too soon, stops that gene's function early, and then that makes that gene not functional. So we have several options for sequencing. The first something we can do is targeted testing. So if we know that a parent has a specific genetic condition, we've talked about NF1, neurofibromatosis type 1. If a parent has that condition and they have a child, we can just go ahead and say, okay, we're going to test for that exact variant in that gene to see if that child is going to be affected with NF1 or not. If we have a person that has features that are suspicious for a certain group of conditions or for a certain condition that can be caused by several genes, we'll do what's called a panel test. And this is when we are looking at just certain genes in the body that are associated with that condition or those group of conditions. Our panels can be as small as, I've done panels that are like 2 or 3 genes, or panels, I have one that I regularly order that's 350 genes. So these can be really large depending on what we're suspicious of, what's available for the lab, what insurance testing is like. So we have a lot of options when it comes to panel testing. Then we have what is becoming much more common now, whole exome sequencing, and then whole genome sequencing, which is going to be coming down the road very soon. So whole exome and whole genome sequencing so as opposed to a panel, which is looking at just part of our genes, whole exome and whole genome are looking at the whole thing, all of the genetic information. So it's looking at all 20,000 of our genes. So whole exome sequencing, or WES, sequences or looks for the spelling errors in the part of the genome that makes the proteins. So we have our whole genome, which is all of our genetic information. About 1% of that is our exome, which is actually the part of our genetic information that's active and the important part that makes those proteins. The rest of that genetic information is kind of filler, it's some support information. So it's not that it's not important, it's just, it's not producing the proteins. But that 1% of the genetic information that's included in our exome is responsible for about 85% of human genetic diseases. So if there's a genetic disease, that is in the exome, there's a really strong, or the genetic disease, there's a really strong chance that we're going to find it looking at the exome. And then whole genome sequencing, it looks at all of that genetic information. So that 1% plus the extra 99%. Whole genome sequencing is becoming more available. It's harder to get covered in Virginia. A lot of our patients have Medicaid, and there's not a lab right now that accepts Virginia Medicaid for whole genome sequencing. That's going to be changing in the next few years. But whole genome sequencing is not as well understood, and it's a little bit harder to interpret. So we don't typically order that on a routine basis just yet, but talk to us in 5 years. This is going to be a completely different conversation. So whole exome sequencing and whole genome sequencing are most informative when a person's parents are included in the sample, or in the testing. We call that trio testing. So when we think about the genetic information we can find, like I said, there are some genetic changes that are completely normal in our bodies. And because genetic testing it sounds like it's been around for a long time, but really in the grand scheme of all of the genetic information that's available, genetic testing has not been around that long. And there are a lot of genetic changes that I'll get to in a minute, but there are a lot of genetic changes that the lab necessarily hasn't seen before. And they say, okay, well, this could be in a gene that's causing these health issues, but we don't know if this means anything. So the first thing the lab's going to do is they're going to look at these samples, if they have a sample from mom and dad or a maternal relative and a paternal relative, and they're going to say, is this something that's in that relative? And if it is, they're going to say, okay, we're less concerned about that. Let's look and see if we can see anything else. Or if it's something that is new in that child, then they're going to say, we're going to take a little bit of a closer look at this. When we're thinking about these single gene disorders, whole genome sequencing has a slightly higher yield than Wes, about 37% versus 30%. But drawbacks to doing whole genome sequencing, it's not, like we said, it's really not well understood, not as well understood as whole exome sequencing is right now. And the results can be really hard for us to interpret. Limited laboratories are performing the testing. Whole exome sequencing, we have several options as far as laboratories, which can help with insurance coverage. But right now, very few laboratories are performing the testing. And because of that, insurance coverage can be poor. And these tests are very expensive. So when we do genetic testing, we can get three broad types of results. So we could get a positive result that said, yes, the test that we ordered found a reason for this person's health features. There might be specific management guidelines. So like Allison was saying, things like NF1, Down syndrome, Turner syndrome, the expert panels, because these conditions are so well described, they have really specific management guidelines for these conditions. And we can say, you know, this is what we predict could happen. This is what we know that we're at risk for. This is what we know the screening guidelines are for. There also could be not a lot known. There are dozens of conditions that are described on a daily basis. So we are rapidly evolving. And when something is described, you know, brand new, I've had patients where we've had 1 or 2 papers in the literature ever published. So we have very little available. So a positive result can give us a name, but it doesn't necessarily say this is what we need to do as a result of this. So then we can get a negative result. So genetic testing didn't find a reason for that person's health features. Reasons for negative testing, there's just not a genetic cause. It could have been the result of lots of little genetic changes, lots of environmental changes, something that we can't test for right now. It could be that there's a variant that was in the part of the genetic information that was not tested. So that could be because we did a panel test and it's not in a gene that wasn't tested, or it could be because it's in the genome information, not in the exome information. Or that our genetic testing just isn't good enough right now to detect a variant that could be there. When we get that testing, we get a negative result back, we talk about following up with genetics and when additional genetic testing might be warranted. And then in the middle, we get this result called a variant of uncertain significance. And that is something that we just don't have enough information to say whether or not it changes the way the gene works and if it causes any health effects. Does not establish a genetic diagnosis. It's unlikely to influence treatment or management, and about 80 to 85% of variants of uncertain significance are eventually downgraded to being benign changes, meaning we know they don't cause health changes. We just don't have that information at this point to make that declaration. So then we also have some direct consumer testing. So this is 23andMe, Ancestry. These are tests that are marketed directly to consumers. So you can go to CVS and you can buy this off the shelf and your doctor's never involved. So these tests have, they make claims about what they can test on the results you can get on this testing. They don't necessarily have a lot of information to back that up. And because this is direct to consumer and this is not clinical testing, they are not held to the same standards that our clinical labs are held to. Our clinical labs are held to very high standards by the government, by insurance companies, by Medicare and Medicaid. In order to be able to bill, they have to meet certain quality standards. And the 23andMe and Ancestry, their labs just don't have to hit those standards. And they don't interpret their test results the same way that we do. They don't get the same information that we get back. And their information can be very convoluted, very gray, and can be hard to interpret. You can get unexpected information. So you can do this testing. You can say, oh, I want to find out if I'm at risk for cholesterol issues or something. And you could find out that you're not related to somebody in your family that you thought you were. And that happens. There's actually there's a genetic counselor in Charlottesville who started a business working specifically with people who have gotten results like that. So it's something to definitely consider if you would like to pursue direct-to-consumer genetic testing. And any genetic test or any result that you would get on direct-to-consumer testing, we would need to confirm in a clinical lab before we would make any recommendations about treatment or management based on those results. And so we've touched on this briefly, but genetic testing can be really expensive. Our major labs don't balance bill people with Medicaid. So people with Medicaid don't get an out-of-pocket bill for genetic testing. But commercial insurance, having a third-party payer varies widely. So there are tools that we can use, benefits investigations, checking with the insurance company about testing prior to sending the testing off, looking at the maximum out-of-pocket for the year. And if you're seeing us in January versus in November, and what the your coverage looks like then. And then our labs really believe in making genetic testing as widely available as possible. So they do have really generous financial assistance policies. And then there are sponsored testing panels that can be explored for people who meet certain criteria and can have their testing sponsored by a research organization.
So in other words, we recommend people don't just assume that insurance is a barrier. Sometimes it is. Yeah, sometimes it is, but there's often things we can do. Yes, I'm going to go super quick through this last part so we can have questions. So what happens after genetic testing? We've touched on this. If it was positive, if we received a specific diagnosis, we give you as much information as you want and that we have available. We make referrals to other specialties if needed. We talk about, does this affect your other family members at all potentially? Does anyone else need to get tested? Does this affect your reproductive options? Are there options you might want to pursue to avoid passing on a certain genetic change? If testing was negative, we can continue, we still discuss it. We talk about any variants of uncertain significance. We talk about our game plan. Are we going to do more testing now? Are we going to think about deferring that to the future? Again, there's other options. There's research-based options available. So there's always things we can consider doing, even if it's negative. And then I think this is kind of one of the last slides. I'll leave this up for a minute. These are just kind of all our local genetics providers. Everyone's great. And then I can go to the next slide with resources in a minute, but that was a whirlwind. We do have a couple minutes for questions if people have questions. Yeah.
I'm nervous about it, but I'm going to ask, what is it, the DETE deletion of UDP Q15?
It sounds like it is a missing portion of a certain gene.
So it doesn't necessarily mean that they could have a syndrome or something.
It's hard for me to say. So with 20,000 genes, I am not familiar with all of them off the top of my head. So I don't want to speculate. But yes, it sounds like there is a missing area of the DNA that includes that gene or includes a portion of that gene.
Okay.
Yes, and I'll put this up too. These are some good resources. Yes.
Talking a lot about the testing, but what would be treatments and supports that you offer?
Yeah, it really depends on kind of the outcome of our testing, or sometimes just what we're seeing when we're evaluating this patient in clinic. There's times where we might say like, oh, we're concerned that you could be having seizures, or we're concerned about something and you're not followed by that provider yet. So sometimes we proactively make those referrals just based on like what we're seeing. In terms of like, if we have a positive genetic testing result, that's when we go to the literature. So sometimes there's guidelines where they say, yes, you have a diagnosis of Down syndrome. That's quite common. We have these expert guidelines. We know that, when you're 5 years old, you should do this. When you're 10 years old, you should do that. So we can kind of just follow the guidelines there. A lot of times with some of the more rare conditions or newly discovered conditions, we might just have to kind of go to the literature and say, okay, well, we know that some individuals with this condition have been reported to have heart issues. So we're going to make a referral to cardiology to get you checked out just to be sure. So it's really quite case specific and individualized. Yeah.
You know, what if this and then how many changes it's done? And you might have to go back to genetics.
Like if your diagnosis changed as a result of your testing.
Well, if somebody changes without the parents knowing,
Mhm.
and then we are fighting insurance about the diagnosis, and should we go back
Mhm.
to the genetics?
It can be helpful, like if somebody is suspected of having a diagnosis
Mhm.
and maybe you need help with disability, help with insurance, help with school, and having a firm diagnosis can help. That's definitely a reason to come see us. You know, if neurology says, I think that this person has
Mhm.
this condition, go to genetics, get that confirmed, and then having that confirmatory diagnosis, you know, maybe we don't have specific treatment or management, but it can help us have that information to be able to help you get the resources that you need. So that's definitely a
Yeah.
reason to come to genetics.
Yeah.
Is there, I know it talks a lot about pediatrics, but is there any age that it's too late?
No.
Mm-mm, mm-mm. Yeah, and I would say, yes, nowadays we get kiddos referred to us, you know, at birth or quite young. But there's a whole generation out there that this testing was not available when they were kids. And it's actually, I don't know, it's quite gratifying to have someone come in who's in their 20s, 30s, 40s, and maybe they had some minimal testing back when they were kids and we just weren't able to find a cause at that point, but our technology has progressed so much that, hey, maybe now there is an answer that was always there, but now we're able to identify it. I would say a lot of times I had this scenario where maybe this individual's siblings are thinking of having kids and that's kind of what brings it up again. But no, it's never too late. Our DNA is the same today, tomorrow, next week. And you know, that diagnostic odyssey is still important, even if you are an adult.
Yeah, I would say like we most commonly see kids, yeah, like younger children, but I've seen people into their 70s.
My son's 46 and they did do genetic, you know,
Yeah.
just the base thing, and they said, no, you know, there wasn't.
Uh-huh.
But since I have a grandson now with autism,
Mhm.
I have another grandson that has the ADD, which I don't know if that gets into. And then, like you said, some of the cancers and things, so.
Mhm.
That's what, you know, whether that would have, you know, maybe that, when they did the testing back then, that didn't do a whole lot, or.
And our
Yeah.
testing has
I
gotten,
just would like to know. if
Yeah.
it's, you know, my, granddaughters, are they going to carry something that,
Mhm.
and then would you talked about like the trio testing or whatever, so would you do the two parents and the handicapped child?
Mhm.
And then would you also do the children without, you know, my sons without disabilities to see if they're hearing?
not in the initial testing usually,
Okay.
because that's not necessarily going to add a whole lot of information. But after we find something, and if we find that it was inherited from a parent, then we can say, you know, here's what's available for testing relatives. If we do testing on parents and we find that it was new in that person and their siblings are not exhibiting the same features, probably less likely that person's impacted.
Mhm. But yeah, I kind of always say, you know, in genetics, our patient is truly the whole family. We're kind of always having that thought process of, we've got our patient in front of us, but how does that affect their family members as well?
Tell us if we had something that could have passed through the two sons that did not have a
Mhm.
disability, it didn't get to their sons.
Mhm.
Yeah.
Okay, would you happen to know what gene problem or genetic problem, what number or letters it would be if it's high cholesterol running in the family?
High cholesterol is hard. So there are some genes that can contribute to somebody having a history of high cholesterol. A lot of high cholesterol is multifactorial, meaning that it is lots of little genetic changes, lots of little environmental changes that we don't really have genetic testing that we can say, this is the particular cause. And then even if we do, there aren't necessarily treatments based on that gene. So we wouldn't say, oh, this person has a change in this gene, put them on this medication. It's still going to be the same management, whether you have a single gene genetic cause or not.
I was wondering why a doctor would do the blood work to check I forget the name of it, to see if high cholesterol runs in the family.
Yeah, there's an exception of people who can have very super high cholesterol that runs in the family. It's called familial hypercholesterolemia. And it's actually relatively common. So that would be I agree with Julie, multifactorial for the most part, but that was probably the main exception, is that familial hypercholesterolemia.
Oh, okay, thank you.
I have several questions. One is, in your training, did you ever learn or talk about spontaneous variants or mutations? Because I have a science background. I didn't know my father. I didn't meet my father until I was 50. And I met him because of wellness. And my intuition was, I don't know half my gene pool. I really should have genetic testing. We're talking 1987. They didn't have something like that. And Fragile X, which is what my two sons had on the carrier for, that was not. I mean, even my first son, who was diagnosed at 16 months, that neurologist was very astute and then kept pursuing it. He tested him in December and he didn't tell me until April 1st or something that he had it. He's why I kept testing it. I'm not sure what that meant.
Yeah.
But this was at Georgetown University, and Georgetown, they told me so many erroneous things. They told my mother that she was the carrier, or she gave it to me, and we got our whole family upset. And then it turned out, once we got involved with the Fragile X people, they said, your mother's results don't make any sense, and they had her retested. So anyway, it turns out it was my dad, but I was already into genealogy, and so when I start looking at the genetics of it and how it mutates, so it doesn't mutate from father to daughter, but it does mutate from mother to child.
It expands, yeah.
Like my number's 90 and my sons are almost 900. And so it occurred to me, they call it a inherited genetic disorder. But I'm like, well, if I have the same number as my father, which was 90, and there's a range that's normal, then his mother, it would have mutated from hers. It seems like she'd almost be in the normal range for it to mutate to 90.
Yeah, Fragile X is a little bit.
At some point it has, I mean, everyone's got the Fragile X gene. It's just in some families.
It expands. It's a little bit of an exception to our normal rules that we think about. But typically, yes, if there's something new that occurs in an individual or a family, we call that a de novo mutation or de novo variant.
And with Fragile X, the lower number of repeats you have, the more like stable it is and the less chance it's going to expand. But yeah, with somebody with a copy number of 90, that's very likely to expand to a full mutation. Yeah.
Quick question. My son was diagnosed with, at your office, probably 10 years ago, for Ehlers-Danlos. I know everybody pronounces that differently, but there was no test at the time. It was just done by visual, scar contact. Is there a test now?
Which type of EDS?
The hypermobility.
No, there's no. So our current understanding is that hypermobile EDS is a multifactorial condition, and we actually don't evaluate for hypermobile type anymore because there is no genetic testing for it, and it's not managed by genetics. So we defer that to primary care, whoever's managing POTS, PT, the people that can help provide
So
management.
what would be the right kind of physician to go to for that? Like just a regular, I mean, I don't feel like his primary care, he's 24 now. His primary care knows absolutely nothing about it.
Usually it's symptom driven. So
Symptom driven, okay.
we, yeah.
who would you, to get started, if you're interested, would you suggest that you go to your provider first and tell them this is something you think, or call the number that you gave
It's
them?
usually, yeah, I mean, it's usually helpful, at least in our clinic, we like to get a lot of records. So it's not that we don't take self-referrals, but we like to have a lot of information to back it up. So a lot of times I think it's easier to like get it put through from the PCP is fine. But if there's like specialists, neurology, cardiology, if there's other people, we kind of want to get all of that if it's not already in our medical record system.
Yeah, so I was gonna say,
Thank you.
especially if someone's not within VCU and the referral's not coming from within VCU, it's helpful for us to start with some medical records. So we have a starting place so we know what other records we need to request from other providers.
Have you guys heard of the combined brain consortium?
Mm-mm.
We just, I took my sons up to Bethesda.
Thank
last
you.
month. They're creating a database